I'd like to get us started again. We're going to get your attention, and please have your seat. We're in a final home stretch for a very busy day. Been really exciting, lots of interesting talks. And it is my pleasure to invite our next speaker up, Hardeep Singh from across the street. He said, don't introduce me, so from across the street, VA Hospital. So Hardeep, it's all yours.
Thank you so much. I think I
may have to unmute your screen.
Okay, there you go.
No, I thought you could talk to blank.
I could. Thank you very much for inviting me. It's a pleasure being here. Unfortunately, I don't have any conflict of interest disclosures, just a whole lot of titles. But I want to also tell you that I'm not a machine learning technical expert. I'm here as a doctor who's going to tell you about some health system problems and get you all very excited and passionate about helping us solve some of the problems I'm going to mention. Let's see. So how many of you have either yourself or a family member has had... Turn the microphone. It's on. How many of you have had a misdiagnosis, either yourselves or in your family? Okay. Keep your hands up. Anyone with a close friend, maybe, with a misdiagnosis? So I would say about a third of the room raised up their hands. So this is clearly an important problem. I'm going to push it down a little bit. Let me know if you can't hear me. I generally tend to speak loud. So what I want to do today is talk to you about the problem of misdiagnosis, give you some things to think about in terms of challenges and opportunities. As you know, healthcare sector is one of the last major sectors to adopt technology, so we're still sort of new at it. We're really slow at it. And one of the questions that everybody has on their mind in healthcare, and maybe outside healthcare too, is this one. All right. So when this reporter approached me several years ago, I told him quite confidently that this is not going to happen in at least my lifetime. It might happen, sometime in the future, but it's not going to happen anytime soon. I was a little skeptical. Even though I'm here standing in front of a machine learning crowd, I'm thinking, oh my God. But then things have started changing a lot in healthcare. A year ago, this is New England Journal of Medicine, our top medical journal, impact factor like more than, I think, 60 or so, had this article about AI and machine learning, and they gave several ideas why it was getting ready for prime time. And again, this is really, things are changing. Some of you may have seen this from 2 weeks ago, where BBC News covered this. This is a paper from Radiology Journal where they looked at MRI scans and a lot of other data to make predictions on who might be getting heart failure and who might be dying from it. So this is, again, progress in machine learning and AI. So I think in healthcare, potential for machine learning is emerging. There's a couple of areas, and I think Craig really built nicely on this, is establish some kind of a patient prognosis, a prediction about what's going to happen, what's going to go wrong. And then the second talk was about trying to displace some doctors. I'm not a radiologist or a pathologist. I'm an internal medicine doctor, and that's one of the reasons I told the reporter that we're not going to get replaced anytime soon. Now, what's not very close in AI and machine learning is accuracy of clinical diagnosis, which is what I want to talk to you about today. So this is a real story of a 12-year-old boy who presented to a New York emergency room with findings of suggestive gastroenteritis. He had some nausea, vomiting, abdominal pain. He also had some leg pain. He also had mottling of the skin, which you really don't see with gastroenteritis. He was seen, he was given fluids, he was sent home after a few hours. Next day, he deteriorated. He died a few days later with sepsis. So streptococcal infection, it was a rip-roaring infection in his body. What they missed was the fact that there was a sign which was suggestive of some other disease, not gastroenteritis. He also, his fluid, when he was given fluids, his blood pressure and his heart rate never responded. And most importantly, they had a blood test report that was abnormal. It was critically abnormal, but it was missed. He was sent home regardless. Nobody followed up on it. So right up till the next day when he came back to the emergency room, nobody knew that he had a critical blood test that was abnormal, needed to be acted upon. It was suggestive of sepsis and infection, and nobody knew about it. So we've been actually trying to solve the problem of diagnosis for a long time. As you can see, the ages of these articles are decades. I mean, we've been struggling with this concept for decades. We have made real progress recently. So this is a National Academy of Medicine report that came out in 2015. I'm still thinking last year because it was 2016, just a few weeks ago. What this really hit home the point was most of us will have a misdiagnosis in our lifetime. So those of you who did not raise your hand, most likely in your lifetime you will have a misdiagnosis if you have not had it yet. So this is a really important problem that we're trying to solve. So we talked about, earlier, Rice professor talked about linear stuff. So in diagnosis, nothing is linear, okay? So it's really hard. But what the Institute of Medicine did was they tried to break it down as a process so we can understand it a lot better than what we do. So we start from the patient experiencing a health problem, visiting the healthcare system, then you go see a doctor, you do a history, they do an exam, they order some blood work, they have some referrals, some consultations, and then you kind of assimilate that information, you gather information, you integrate information, you have a hypothesis, you make some judgments based on the hypothesis, and then you do something to the patient. So you communicate the diagnosis, and then the patient gets treatment. So they try to break it down as a sort of a linear process, but you can see it's not really a linear process because there's a lot going on at the same time. But this is an important conceptual model for anybody who wants to investigate diagnosis, in terms of either machine learning or AI or anything else you want to do with diagnosis. You really need to understand this model well. Why has it been slow progress of misdiagnosis? I showed you those articles from 50 years ago. The basic science of what we are trying to do here. So I'm a health services researcher, so I don't have any technical IT background, but I work with a lot of people who have technical backgrounds. So I work with the cognitive scientists who actually trained at Rice. I work with the informatician, human factors. All of these people have to get together to sort of think about the diagnostic process. And you'll see some of these things will become easier why this happens. We don't have any good standards in diagnosis. So is this a diagnosis of rheumatoid arthritis or is this not? We're always sort of struggling. Things are not very black and white in terms of diagnosis. There's always evolution of diagnosis. So if you think about a patient who presents to a doctor at a certain length of time, they order tests. A few months later, they have more tests. They go to a subspecialist. Then they get an MRI. And then they get hospitalized. All of those diagnoses evolve over time. All those symptoms and presentations, change, and you have to rethink your thinking a lot of times. It's easier to do this stuff on MRIs and slides, but there's not clear-cut binary judgments involved as far as clinical diagnosis is concerned. So there's a lot of opportunity here because our work has shown that there's plenty of failures going around. So I gave you a clinical example. Here's another one, failure to elicit or act upon key history exam findings or red flags. So the example I gave you was that of Rory Staunton, the 12-year-old boy who presented to the New York hospital. But I'm going to give you another one, overlooking documented information in electronic health records. So now doctors use electronic health records as tools to give clinical care. We're still sort of learning how to use them. Essentially, over the last decade is when we have started adopting these systems. So we're still figuring out how to use them effectively. Some of us are still learning how to type. So, it's been a challenge. And how it affects the way we think is a problem. So the patients now say, they go to the doctor and the doctor is literally typing on the computer most of the time and not talking to them and thinking as much. There's a lot of administrative pressures with it. So let's give a case. How many of you remember the Ebola misdiagnosis in Dallas, Texas a few years ago when everybody was scared that we were all going to get Ebola and die? So this is a patient who had a very thick West African accent who presented to the Dallas emergency room, told the nurse, who documented in the medical record, that the patient was in West Africa. He had fever, he had all the other symptoms. He spent time with the doctor. The doctor really didn't get the travel history from West Africa documented. It wasn't documented. The doctor didn't know. He was sent home with a diagnosis of sinusitis, and then he came back later with the diagnosis of Ebola. Now, the nurse didn't communicate that information to the doctor. Any nurses in the audience? Don't see any. But oftentimes, they're sort of working in different environments. They don't necessarily directly communicate. And especially now with technology, you rely on the other person to read your note. But the problem is doctors don't often read the nurse's note. And each of them, you ask the nurses and they'll tell you it's not something that I made up. The problem now was the patient was sent home. The doctor's note said no fever. because they were using templates. So when you use a template, you just go down the template, check, 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 and you sort of miss the fact that the patient came with 103 fever. So we think that the doctor's thinking was, disturbed by spending a lot of time with the computer, entering data and not talking to the patient, and also not looking at the data that was available to them in the medical records through the nurse. Wish list here. So I wanted to talk about challenges and opportunities. I think this could be a great opportunity for people who want to generate algorithms, to generate some differential diagnosis. People are sort of doing that in healthcare. Not being used very frequently. There's several reasons why, and I'm going to tell you in a minute. Algorithms could also suggest, high-value tests. So we waste a lot of money ordering unnecessary tests as, healthcare providers. We sometimes get procedures that are not needed, tests that are not needed. And so, we could do this. ML, machine learning, could help us here. But the problem is a lot of this data is in unstructured text. So this is like notes that I'm writing. Remember all that typing that I'm doing? It's on the notes. So it's not easily accessible, this data. Another challenge is, so you could take this data and then you could provide some alerts and reminders to doctors, and Craig gave an example of some alerts as well, but we're ignoring the alerts that we have right now. So there's medication alerts that suggest that there's critical drug-drug interaction that the doctors would ignore these alerts. So we do have a problem. And most important, people don't realize this, that doctors often don't seek help when they most needed. And I'm going to show you an example why this is important. And so everybody thinks, I want to just build that great app, the great technology, I'm going to show it to the doctor and they're going to use it just like this and everything's going to be better. But the problem is doctors often don't use the tools that we have, that they're given either. Here's an example of what can go wrong here. And this is a study that we did where we showed vignettes of 2 easy cases and 2 really, really difficult cases to the same doctor, all right? So you would think that if I'm in the middle of a really hard, challenging case, I really wouldn't be that confident because I would be very uncertain about what's going on. I would probably ask for help, right? I would say, hey, I want to get a consultant, call my friend, or get some more, use a differential diagnosis generator, or use some decision support to help me do my job. But that may not always happen. So here's the graph that sort of shows you what we saw in our study. So one on the left shows the easy cases. So if you look, the confidence is around 0.7, okay? The accuracy was hovering around 56%, the accuracy of the case. So we asked them, what is your differential diagnosis? Are you confident that you are correct? On the right side, when they were given very difficult, challenging cases, their diagnostic accuracy dropped to about 6%. Remember, it was 56%? It dropped to 6%. That means only 6% of the doctors got those hard cases correctly. What happens to their confidence? It barely budged. They were still very confident. They knew what they were doing. And so, we also asked them, would you like to seek help? Would you like to order tests? Would you like to order a referral? Would you call a friend, like we call it curbsides? Would you like to seek reference material? Books? Nope. So, you could build models and validate them. But you're going to have to do that individually for many of the commonly misdiagnosed conditions. So you would ask me, hey, tell us the few things that you misdiagnosed, and we'll fix those things as a start. Great. Here's a list. Look at those numbers. 4.5%. That means this is from a different study that we did, a separate study out of 190 errors, or 190 misdiagnosed patients. There were 67 different diseases that were involved. So how many models are we going to build around how many diseases, right? Additional challenges, validating the models. Well, as doctors, we hardly agree on just about anything. Okay, so you show the same case to two or three different doctors, you'll get like 5 different opinions. So we don't often agree on, is this the right diagnosis or not, or is this the correct diagnosis, or what kind of diagnosis are. So you will take several clinicians to validate these models. Then you could say, well, maybe we'll start with the symptoms. So that Rory Staunton story, I told you, the nausea, vomiting. Let's maybe start from symptoms and then figure out the diagnosis part. Let's validate sort of a model based on symptoms. The problem is, a third of the cases in our study of misdiagnosis had symptoms that were completely unrelated to what was ultimately the misdiagnosis. So it may have been a patient with pneumonia, but they may have come to the hospital with leg pain or back pain. Something may not be directly related. So it's really hard trying to connect the dots between the presentation of the patient and the disease that they ultimately were misdiagnosed with. So other areas where I think there are clear opportunities is information overload. This came up in the last talk as well. We have a lot of data, and now with the electronic data, this is more and more data that we're sort of seeing in healthcare. And the other thing you can help us with is to figure out who's at increased risk for missed or delayed diagnosis. So where are we missing? So remember to think about the Ebola patient or Rory Staunton. Help us figure out who are we going to miss or whose diagnosis may be getting delayed. So here's a problem in healthcare, which I think is really ready for prime time. This is a study. We asked docs about, information overload, and they get a lot of reminders and alerts through the electronic health record. And about 30% of them said that because of this information overload, they miss abnormal test results. So these are abnormal chest x-rays, abnormal thyroid function tests, anemia. They're missing stuff because of so much information overload. And more digital data is on the way. So I know lots of people are enthusiastic about wearables and all the big data that's going to be sent to the doctors directly. Most of the doctors that I talk to are not really ready to see all this data because they still can't even manage the electronic health record data that's coming their way. So I know lots of excitement, but I think we need to create better value from this data before we actually do something meaningful with it. But here is an area of promise. This is a study we did where we looked at structured data using abnormal radiology films that were not followed up in a certain length of time. So you go to the doctor, you have an abnormal chest x-ray, it shows some kind of nodule, and now you need follow-up. So we had previously shown that about 8 to 9% of patients who have abnormal chest x-rays or abnormal CAT scans do not get follow-up in 30 days. That means in 30 days, nothing was done. Imagine you've got a mass sitting on your lung and nobody knows about it. So we built algorithms to identify on big data. This is VA national data from 150 plus VA hospitals. It's huge. Where we validate, again, we're not even getting close to some of the cool stuff that you all could be able to do. But essentially, we thought, where are the patients who are falling through the cracks? Where are the needles in the haystack? Can we identify the needles in the haystack by making the haystack smaller and by attracting the needles using a magnet? So we made our algorithm smarter and smarter. So you don't want to do this algorithm on patients who are dead. Right? You're only looking for living patients. We only want to look for patients who have, let's say, don't have a diagnosis of lung cancer. So we made the algorithm smarter, and we got a pretty good predictive value. 6 out of the 10 patients that we identify using this algorithm truly are lost to follow-up. That means they have not had the follow-up that they needed, which is pretty good because right now, what we're doing right now in healthcare to identify these patients is zero. We are not able to find these patients easily. Couple of things I want to sort of close up with is it's really essential to use this, what we call this multifaceted socio-technical approach. This is a model that we developed and it's sort of written about and it's fairly increasingly accepted in the health IT world, where we have 8 dimensions and most of us live within just one dimension and we forget about the others and they all sort of get siloed. But essentially to solve the problem of something like electronic health records and misdiagnosis, we need a larger conceptual model to figure out how to do things right. So in our model, you really have to think about all of those things, for instance, in this picture, in order to make sure that we're making effect. So how do you change practice from where you are. So you can't only think of the software, but you got to think about how you're going to display that information to the doctor. Is it going to be within their workflow or not? Are the organization's policies and procedures supportive of what we were going to do? Are we going to be able to have the regulations that support the doctor's work, so on and so forth? So you've got to think about that. And I want to sort of close up. This is my last sort of wish list is, I think we've got to all work on a team. This is my team, so I've just showed you as an example. I have informatics, psychology, IT, sociology, human factors, all working together because myself, we're not going to be able to solve this challenge without my team. So I think working in larger multidisciplinary teams is really the way forward for anything that we do with machine learning and trying to bring that into real world practice. All right, thank you very much. This is my contact information, and I want to thank my funding agencies as well.
We have time for a couple of questions. Moshe?
The issue really machine learning or the issue the clinical courses, re-engineering the clinical courses?
Yeah, great question. Is it just a machine learning problem or the process problem? This is where the model is really useful, because I think it's a little bit of both. I think right now it's the processes. So if you ask doctors about what they really need, they'll ask you, I need more time to spend with the patient. I need technology or my computer that's easier for me to use. I think we're still far away. So that's why my skepticism is still there about, are we ready for prime time as far as the accuracy is concerned or not? I truly agree with that.
Thomas?
I guess what it sounded like to me was that this is fundamentally a cognitive bias problem. That particularly when you see enormous gaps open up between accuracy and confidence in accuracy, that's normally an indicator that there are deep-seated cognitive biases that are built into the system, and nobody has thought about how to engineer the work process or workflow in a way that mitigates those cognitive biases.
Again, an excellent point, and I really agree with you that this is there are lots of cognitive biases involved in the way we think. The problem is our understanding of some of these biases, we're not ready yet, because there was a study recently where even expert clinicians who were familiar with cognitive science couldn't tell one bias from the other reliably. And so they're present, but the problem is I'm not sure how actionable they are. So are we going to be able to fix those biases? So you can do some de-biasing, but I think ultimately it's going to come around using some kind of a systems and process-based approach to overcome those cognitive biases.
I'll just give a follow-up example from my company. A number of years ago, we realized that I'm in the oil industry, that our assessment of subsurface uncertainty was always an underestimate. And when we realized that, we redesigned our workflows and our ways of analyzing the subsurface in such a way that I think now we essentially understand how much we understand. It may not be enough about what we're trying to do. Now, medicine is hard. People are always going to misdiagnose. The problem that you've demonstrated very clearly is that people don't know how much they understand. And that there are sociological ways of addressing that.
Exactly. Get your point, and I think we call it sort of calibration. So you got to have a better calibration between what you know and what you don't know. So great point. Thanks.
We have one more question over there.
So in the machinery industry, we have the first line of defense with machine learning, but then we have generally kind of people that are maybe ex-operators, maintenance people that will look at that information before they call the doctor or the specialist to tell them, we think we got an equipment problem. Don't you think, likewise, in people health, non-machinery health, with nurses or physician assistant kind of play a similar role where they can actually lower that burden to doctors?
Yeah. The Institute of Medicine, the first recommendation they have, the report that I showed you, was team-based diagnosis. So they said you got to start working in teams. Essentially, I think that's what you're describing. Yep.
We have one more question here.
I'm a studying student from Civil Biomedical Informatics Health. So I'm also doing text mining in clinical. So you have mentioned that a major proportion of the data stored in EHR are unstructured text. So what kind of the information or knowledge you want to extract from those arbitrary tests in your test.
So what kind of information? Yeah, I mean, it could be a lot, right? So you could have information on the patient refused care, or you could have information that the patient got their test somewhere else, so you don't have to worry about it in the algorithm. The problem is a lot of this is in the unstructured test, but there's also a lot of inference that needs to be made regarding the clinical diagnosis. Not, is this diagnosed? So you could use natural language processing, but I think you won't get to that same level of intelligence that you need.
Please join me in thanking our speaker. Yeah.